The recording will be posted on the board's webpage shortly after the meeting. TBW may also be streaming this meeting live and archiving it for additional viewing opportunities. For everyone's reference, today's agenda can be found under the first tab in the materials. Sue Birch, Chair of the Healthcare Cost Transparency Board, will now call the meeting to order.
Great, thank you. Welcome, board members. It is 2:04. Hear that gavel? I'm calling the September 19th meeting of the Healthcare Cost Transparency Board to order. I want to just welcome everybody today joining us. It looks like we are 40-something strong, approaching 50, with more participants calling in. And we have a very full and lively meeting scheduled for today. I just came off several national meetings where affordability and cost containment are some of the key topics. I also was honored to listen in to 4 CMS administrators, moderated by the Dean of Johns Hopkins, on kind of the longitudinal look at what's happening. And everybody is saying, you know, we did so great with bringing up Obamacare, getting people covered, building up access, but it is time for us to focus on cost containment and affordability. So I think that, you know, the messages nationally continue to be a resounding, we got to dig in and do the hard work of exactly what our charter and what our board is up to. So that's kind of exciting that we're converging with that national movement. And of course, we've been a pace setter and leader in this work. We're going to focus on our tools, our possible actions. We're going to have discussion on facility fees, one of the board's selected policy priorities for examination that we picked up on in February. And then we're going to also discuss the recommendations from the board's primary care committee. Our very own Jane Beyer is going to present the Office of Insurance Commissioner's final affordability report, and we're going to examine the initiatives being undertaken by state agencies to address healthcare affordability. By looking at these parallel efforts, we're going to be able to identify opportunities for collaboration that might enhance or force multiply our own strategies. In all the themes of these national meetings, there was a lot of discussion about trying to get more uniformity and get more convergence on the levers that different state agencies are pulling and undertaking. So we also recognize there's not a single solution, and we've got to be doing a number of things, and it's unlikely that we're going to resolve the complexities of these issues with just a few singular moves, which is why we got to keep examining the different strategies and approaches, and we've got to keep thinking about them from various angles, which is why your input is so important. We aim to develop comprehensive recommendations to manage and reduce healthcare costs for Washingtonians, and there's some urgency about this because our legislature and future governor are going to need some ideas from our group about what they should be doing and what they should be driving towards. Rising healthcare costs are one of the biggest reasons people delay or forego healthcare, making healthcare costs an underlying barrier to access for many. And if healthcare costs continue to increase, we will see more Washingtonians forego or delay that necessary medical care, putting their lives at risk and further driving up costs to the systems. So again, that is why our work to identify, evaluate, and recommend policies is crucial to Washingtonians and their futures. Our legislative assignment to identify, evaluate, and recommend effective policies is vital to improving the healthcare landscape for Washingtonians. It's essential that we continue to push forward with our recommendations and our collective efforts to ensure these recommendations are available for the upcoming legislative session. We cannot let perfect get in the way of good, and we will be able to course correct with our partners in the industries as we continue to move forward and investigate more what exactly is going on. So I'd like to move us into our agenda. If you all will turn to tab 1, we're going to do the roll call real quick. Jane Beyer.
Here.
I saw you on. Eileen Cody.
Here.
And Jane, I acknowledge you're in the room. Eileen, I'm glad you're feeling better from COVID. Lois Cook.
Here.
Thank you. Hi, Lois. Bianca Frogner.
Here.
Thank you. Jody Joyce.
Here.
Hi, Jody. Greg Marchand. Greg is a little busy with Boeing stuff, but he did tell me he'll be in and out of the meeting. So staff, will you let me know when Greg jumps on? Okay, Mark Siegel. And let me know if Mark jumps on. Margaret Stanley.
Here.
Hi, Margaret. Ingrid Ulrey.
Here.
Great. Kim Wallace.
Here.
Carol Wilms. I think she told us she's not able to make it. Carol, are you on? Carol's not on. She's, I think, excused. And Edwin Long.
I'm here.
Hi, Edwin. Great. So we've got quite a full house, and staff, you'll let us know if that changes at all. So let's move into our next item on the agenda, the approval of the July meeting summary. And if you want to go to tab 2, the meeting summary, that would be great. I think we've also got it up on the screen. As a note, the recording of the last meeting is posted on our webpage for reference or review. We're going to use a consensus process for a vote on the approval of the meeting summary. Have people had enough time to look that over? And is there any discussion of the July meeting summary, or are there any proposed changes? And Kim, I see your hand up.
I do have one question. So it is in the section, I think it was page 3. It's a section where Suzanne was speaking. We're capturing what Suzanne had to offer. So could we scroll to that? Let's see, it's a bottom of the
No,
page.
page 3. Suzanne
Yes.
talked about the Seattle Children's
Yes.
Clinics. Yes, that
Yes,
paragraph.
yes. I have I'm not seeing, oh gosh, let's see. I'm not seeing the line that I have a comment about. Maybe it's just truncating off my screen here. There's a comment. It awkwardly keeps jumping back and forth. There's let's see.
I can read it.
Okay, it's the sentence, I believe it's the second or third sentence in the paragraph. It says that if hospital is speaking about about the clinics
Yeah.
providing hospital services not being able to charge facility fees. I think it says could, I think that we're missing a word not. Could not?
Yes, I see what you're saying. These clinics would not be available if hospital services provided could not be reimbursed like a hospital. So we need to insert the word
Right, not.
could not be reimbursed. Thank you for
Right.
catching that, Kim.
Okay, you're welcome.
Yeah, because they were expressing concern about many of these services not being viable. All right, other recommended changes. I'm not hearing any. We'll use that consensus process for a vote. Is there a motion to approve the minutes?
So moved.
Thank you, Eileen. Is there a second?
Second.
Thank you, Margaret. All in favor, say aye.
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 Great. Any opposed? All right, the motion is approved to receive the July meeting summary. Thank you for that. Next, I'm going to welcome public comment, and I remind the board we moved this up in the process so that people could chime in early on. Can I ask Mandy to help me with this process? Who do we have in the queue?
Be happy to. Just as a note, if you're providing public comments, please identify your name and your affiliation before speaking. And the first person I have for public comments is Bill Robertson, who signed up. Bill Robertson.
So Bill, and yeah, as Mandy said, we do get written public comments. And so if anybody doesn't want to speak up or be in the queue, they can submit things in writing to us anytime. But this is the opportunity for people to signal that they would like to speak. So we'll go ahead. If Bill, if you will identify yourself and state your affiliation, before speaking, and we welcome your comments to the board. Mandy, are we opening him up to speak?
Saw that he was switched over already, but
Yes. I had to
There
turn
he
on
is.
my microphone. I would have learned that over 4 years, right?
We recognize your voice, Bill.
Yes. Well, thank you for the opportunity to provide public comment. My name is Bill Robertson, and it is my privilege to serve as the CEO of MultiCare Health System. Today, I'll be commenting on the rate setting proposal in the OIC's final affordability report and on facility fees. MultiCare's roots go back to 1882 with the founding of Tacoma's first hospital. Over the years, we've grown from a Tacoma-centric hospital-based organization into the largest community-based, locally governed system of health in the state. Today, we operate more than 300 primary, urgent, pediatric, and specialty care clinics, a comprehensive continuum of behavioral health services, and 12, soon to be 13, hospitals. Not only are we a healthcare provider, we are also a major employer in Washington with nearly 24,000 team members. Like many organizations represented on the board, we are a significant healthcare purchaser with a very strong interest in cost containment. For the past decade and going forward, a central pillar of MultiCare's strategic agenda is lowering the total cost of care for the patients and communities we serve. Today, we have risk-based contracts covering over 400,000 people, in which total cost of care is a significant component of success. Prior to my current role, I spent 14 years as the CEO of Adventist Healthcare based in Gaithersburg, Maryland, an organization that, like all health systems in Maryland, was significantly impacted by the Maryland rate setting system. My experience with the rate setting system was that it failed in controlling costs and created an array of time-consuming, expensive, and non-value-added regulatory challenges. Even though it sets hospital payment rates, Maryland's all-payer model has done little to produce lower costs of care. Maryland started with much higher costs than the nation, and after 50 years of rate setting, it is still, according to Kaiser Family Foundation, ranked 18th in per capita healthcare spending, with first being the highest cost and 50th the lowest. Washington is ranked 40th. Maryland spends 17% more per person on health care than do Washingtonians. According to CMS, the limited cost savings realized in Maryland have largely occurred through reductions in ED admissions, which was achieved by shifting care toward outpatient ambulatory sites with lower costs, which was already accomplished a number of years ago in Washington through an initiative with ER physicians. And the second was lowering costs for professional services and reducing some post-acute utilization of post-acute care. Additionally to the challenges of the rate setting system, it's unlikely to be replicated here. A similar program in Washington would cost the Medicare program at least $3 billion more than it does currently. And the state of Washington would have to increase spending on the Medicaid program by significantly more than that $3 billion. A Maryland-esque rate-setting system is not a viable solution for Washington. It would fail here just as it has failed for the past 50 years in Maryland. Now on to facility fees. As I mentioned, we are a community-based organization, and we serve in both rural and urban areas. In our Yakima region, 48% of our patients are covered by Medicare and 23% are covered by Medicaid, and that's similar to our urban markets. Medicare only pays about 83% of cost in Washington. Even with recent state increases in Medicaid reimbursement, we're still at or below what the Medicare rates are. And paid significantly less than cost for Medicaid services. These payment rates are unsustainable. We can't make it up on volume. When you lose on every one, you can't make it up on volume. And that's for both hospital-owned or non-hospital-owned outpatient services. Facility fees help cover the costs associated with staffing, supplies, equipment, buildings. Without them, Medicare would not be able to continue operating in the area in Yakima because the payment rates are unsustainable. The services provided to patients that would be unsustainable are outpatient service, surgery, inpatient imaging services, and primary care. Eliminating facility fees does not come without a cost to the healthcare system, especially in rural communities. There might be some reduction in bill charges to patients, but there would be a dramatic reduction in access. I urge you to consider the impact to patient access before moving forward with your recommendations. And I appreciate the opportunity to speak to these two topics today.
Bill, thank you for those comments. We appreciate it. And we're going to move on to the next person that would like to provide public comment.
Sarah?
I think you said Sierra.
Drew?
Oh, I'm sorry. It's Drew Oliverio.
Yes.
Drew, if you want to open up your mic.
I should be open if you can
There
hear
you
me.
go. We've got you now.
Great. Hey, thank you for the comments. This is Drew Oliveira. I'm the Executive Director of the Washington Health Alliance. We're an independent, non-government entity. Many of you are members. Bill Robertson, thank you for being a member. We love working with the multi-care group, especially in your purchaser role, because you bring a lot of good insights to our purchasing members. My only comment is related to what was discussed back in July regarding facility fees. We do operate an all-payer claims database. We would certainly be interested in looking at facility fees. We'd need the sort of definition of which fees you want to review. We heard from Pro-Alliance last time about, they do charge a facility fee for when they do procedures. That seems to make a lot of sense. And I think being able to catalog when facility fees are occurring, when are they appropriate, when are they, maybe there's some question about that. Maybe in certain settings it's more appropriate than others. We'd be happy to look at that and work with the HCA in terms of doing that type of analysis.
Great. Thank you for that comment, Drew. And I'm sure the board will take that under advisement as we keep probing into all things related to costs and trying to drive more industry efficiency and uniformity. Mandy, who do we have next?
Jeb Shepherd?
Jeb Shepherd?
Yes.
Yeah.
Go ahead and
Thank you,
open.
Mandy.
There you go.
Thank you, Mandy. Thank you, Director Birch. Good afternoon. My name is Jeb Shepherd. I'm the Director of Policy at the Washington State Medical Association. We represent physicians across the entire state in all specialties and practice settings. Thank you for the opportunity to provide public comment during your meeting today. I'd like to focus my remarks on two separate but related areas: the OIC final report on affordability and the forthcoming Healthcare Cost Transparency Board report to the legislature. WSMA commends the legislature and the Office of the Insurance Commissioner on its work to understand rising healthcare costs and offer solutions aimed at making healthcare more affordable for Washingtonians. That is a goal that is shared by physicians in this state. Speaking for the independent medical group community, I would respectfully point out that reference-based pricing and enforcement of the benchmark seem to assume that physician practices operate on fixed costs. However, the overhead and direct costs of delivering healthcare in the physician office, including increasing costs of medical supplies, staff salary and benefits, pharmaceuticals, office rent, utilities, unequally applied state B&O taxes, high licensure fees, complying with the ever-growing state, federal insurance carrier administrative requirements, and so forth, are not fixed costs. While these costs have been going up, reimbursement for physician practices have been trending down. A few examples: Washington State ranks among the lowest in the nation for Medicaid reimbursement for specialists. On average, the state pays about 57% of the Medicare rate. Only two other states, Rhode Island and New Jersey, pay lower rates. When adjusting for inflation, physician reimbursement in Medicare has declined 29% since 2001. The physician fee schedule is the only Medicare fee schedule that is not indexed to inflation and does not receive annual updates. Insurance carriers, as you know, utilize the physician fee schedule to index their rates. And we've heard from many members in small and mid-sized practices that have no market leverage, including just this morning, that they are routinely presented with take it or leave it contracts without the ability to negotiate and cover their costs. This is an unsustainable course, as evidenced by many practice closures and increased consolidation over the last decade plus. This is an area of concern and focus for the board. Physician practices are like a pressure release for our healthcare system. It's the setting where conditions are diagnosed and managed, and when access to this setting is limited or goes away, patients seek routine care in higher cost settings for conditions that have worsened. Therefore, we implore caution, and therefore we caution implementation of these policies broad enough to include independent physician practices. As the board considers next steps, we suggest an actionable report to the legislature from the Transparency Board should include an analysis of underlying cost drivers. The focus shouldn't simply confirm that prices are increasing. We all know that, but why? We believe a strong report would also look at both the potential positive and adverse impacts of each policy proposal. This is information that lawmakers need to make informed and responsible policy decisions. In summary, healthcare delivery in this country is very difficult and expensive to deliver. Physician practices need support from policymakers that make it easier and more affordable to deliver care and manage conditions in lower cost settings, such as improved reimbursement rates for physician practices and administrative burden relief, and would encourage analysis of these approaches to reduce costs in your report to the legislature. To that end, I would be remiss in not thanking the legislature, the Healthcare Authority, and specifically Dr. Zerzan for their work to improve access and quality to primary care in our state. Please continue to consider WISMA a partner and resource in your important work, and thanks for your time today.
Thank you, Jeb. Mandy, who is next in our queue? And Mandy, I would just wonder how many more we have.
You have two
in the
individuals
queue.
left in your queue, and Caitlin Safford. And then
Okay.
Perez, if you
And
would.
I'm gonna just ask commenters to please, we have others, please keep your comments brief, and go ahead, Caitlin, if you want to open up and share your comments with the board.
Thank you. Good afternoon. I apologize for my voice. I'm also recovering from COVID. My name is Caitlin Safford. I'm a senior policy director on the government affairs team here at the Washington State Hospital Association. We wanted to provide the WSHA perspective on the final OIC report on affordability. We submitted comments on the preliminary report. And some of those are repeated here, so I'll do my best to keep those comments brief. And we know the report itself is final, but we do hope you consider some of our remarks as you develop actual policy recommendations for the legislature to consider. We're concerned because 2 of the 5 recommendations on the OIC list concentrate based on hospitals and are aimed specifically at hospital rates. But the board itself has established that hospital rates are not the driver of increases. The board's cost driver report shows inpatient costs have actually been flat over the past 5 years, while outpatient costs have been growing at high rates. The growth has been caused by increased use rather than price increases. Additionally, moving to outpatient care has actually long been the established state and federal policy preference to reduce inpatient costs. And based on the cost report, hospitals are clearly following this policy precedent. So we're confused as to why global rate setting and reference-based pricing, which both focus on rates and hospital rates specifically, are 2 of the proposed solutions. Specifically on reference-based pricing, the most important note is that, and as Jeb was commenting, Medicare reference-based approach doesn't actually cover the cost of care for hospitals. And since Medicare rates are designed for a specific population, mostly elderly patients, it also doesn't provide a reference for certain services that hospitals provide substantially, which includes obstetric care. To further weaken the conclusions in the initial data set used as a basis for the analysis, they did show that commercial rates were actually lower than expected. And as a result, the savings were limited for the other states that are compared. The consultants who contributed to the report even state that further work is needed to understand the impact. We'd really encourage the board to consider, and OAC to consider, that before embarking on any reference-based pricing effort, we believe significant analysis is needed to identify how both hospitals and providers would be affected and how impactful unintended consequences could be. Bill actually spoke a lot about global budgeting, so I'll leave the comments to what Bill addressed. But we did want to speak to the recommendation from the OIC report on adding enforcement mechanisms for the board's benchmark goal. There's no specific recommendation on how the savings accrued would be passed on to consumers, and we think that's a really important consideration for the board to make. We want to ensure that any savings seen are actually passed down to the actual individual consuming care. And we continue to believe additional enforcement mechanisms are not appropriate until the board has a track record of developing goals and recommendations for providers on how these goals can be achieved in a feasible way. I'll leave my comments at that for today. Thank you, Sue.
Thank you, Caitlin. The board appreciates your public comments. Mandy, do we have any other presenters?
Chris Ramirez. And I show that that is the last public comment.
Okay, Chris, if you'll open up your mic and camera and identify yourself and your affiliation and state your comments to the board.
Yes, thank you for the opportunity to provide comments today. My name is Chris Ramirez, Senior Policy Advisor at Seattle Children's. In July, you heard from our Chief Financial Officer, Suzanne Beitel, on facility fees. Despite her compelling testimony, we continue to hear terms like cash grab. Simply stated, nothing could be further from the truth. Without facility fees, Children's would have to make decisions about potentially discontinuing certain services at our regional clinics, which puts the burden on families to drive to Seattle. The two areas that would be most impacted would be access to specialty care and equity. Seattle Children's has a main campus at Seattle and serves patients in regional hospital-based clinics located in Federal Way, Everett, and Bellevue. These clinics provide complex diagnostic and therapeutic services to children, regardless of their ability to pay. All of these clinics were additions to the communities in which they are located. They were not clinics acquired by the hospital and converted to be hospital-based. At these sites, we do surgeries, sedated advanced imaging to toddlers, and we infuse strong medications to adolescents. We open these clinics to increase access and to be more convenient to families, especially those most socioeconomically disadvantaged. At these clinics, 49% of our patients are Black, Indigenous, and people of color. 76 different languages are spoken, and more than 50% of our children's patients have Medicaid insurance coverage. In 2023, Seattle Children's saw nearly 400,000 patients, and 41% of those visits were at the clinic-based setting. We are delivering care closer to home. As a person of color, I've seen firsthand how important these facilities and services are to communities of color. These services cannot be continued without maintaining facility fees. We urge the board to consider the impact on access to care and engage in a cost-benefit analysis before endorsing any cuts to healthcare services in Washington State. Thank you.
Thank you for those comments, Chris. I think, is there anybody in the room, Mandy?
No.
Okay, I think that wraps up our public comment period. Again, those presenting, thank you for your comments. The board always digests them and talks about them. And board members, I remind you too, we will forward you any of the written comments that come in between, and you're seeing on the screen the ones that have come in. All right, we are going to move on. Next, Eileen Cody, who is the chair of our Advisory Committee of Healthcare Stakeholders, is going to provide an update from the committee on work assigned to the committee from the board. And I remind you that stemming from Noam Levy's presentation on medical debt in America, the board requested this committee examine medical debt and to evaluate and suggest appropriate policy solutions addressing medical debt for the board's consideration, such as some of the policy ideas identified by Noam. So Eileen, I'll turn it over to you. Thank you for doing this body of work for our board.
Okay, thank you, Sue. I will try and keep it brief so we can get back on schedule. We did welcome a new committee member, as stated on the slide, Michelle Ritala, and we did have a pretty robust discussion about medical debt. We had a presentation on it, again, from the Center on Health Insurance Reforms based on the Commonwealth Report. And we also had some medical debt policy prioritization discussions. We're going to continue those at the next meeting, which is in November. We also have received comments from the members, that's if you go to the second slide, we have that. The one thing I would point out that there was some frustration that we heard from some of our members because they didn't quite understand why we were focusing on medical debt instead of trying to make sure that medical debt didn't happen. So I just kind of wanted to pass that back to the board. They felt like we were supposed to be lowering costs of healthcare more than trying to figure out how to protect people on the medical debt. But that we went through that discussion and explained to them that was the job of the committee, was to give us ideas. So as you can see, they're consumers. We have this divided up. It's not necessarily, I wanted to make clear that it's not just that the consumers said this, the hospital said it, it's about each individual. So in other words, what different ideas that would affect consumers, the different ideas that would affect the debt collectors and the hospitals and insurers. So that I just wanted to clarify that in this slide. Actually, I don't think I have a whole lot more to say on that. I think that we're going to, as I said, we're going to continue discussions and hopefully we'll be able to come back with some recommendations for the board. Any questions?
Great. Thank you, Eileen, for serving as the chair of that effort. And are there any other questions from the board? Okay, hearing none, we're going to move on to Bianca Frogner. She is our chair of the Advisory Committee on Data Issues, and she's going to provide updates from the Advisory Committee on data issues. And I remind you that the board assigned this committee to investigate current data reporting structure in Washington and capture this information to provide back to the board when the board evaluates business oversight recommendations. Thank you, Bianca. Over to you.
Yeah, thank you. And apologies ahead of time. I'm getting over a chest cold. So unlike COVID, I might be coughing. So I apologize ahead of time. So we had a meeting where in August where we introduced a new committee member, David Giuseppe, who we'll probably have to actually reintroduce again at the next meeting because he wasn't there. We want to give him a proper introduction and welcome. We focused on business oversight, reviewing again where this fit in the board's priorities from our retreat earlier this year. And so, excuse me, we reviewed briefly where business oversight has been discussed within our own board and within the Data Issues Committee. But we spent most of our time hearing from a slate of panelists, including our own Jane Beyer. So thank you for her participation there. Mandy Stair from the Office of Financial Management, Travis Kennedy from the Attorney General's Office, and Ian Doyle from the Department of Revenue. And each of them talked a bit about the through lines and challenges across the different agencies and collecting data, especially around mergers and acquisitions. We had a robust discussion about data and availability of data, and similar to like what Eileen heard in her subcommittee, I think we also heard some frustrations about why the focus on mergers and acquisitions, and particularly with an eye on feeling that maybe there's a lot of data already being collected in this area. So there, I think, was just a call that we should be sure that we're not duplicating efforts that might be done elsewhere in the state. And so I think it was a good, robust discussion. I emphasize that the point of the Data Issues Committee is where we have this opportunity to hash out these issues and identify where the data are being done, what's missing, and what data do exist. So we will be hearing from the Department of Health at the next meeting, and that next meeting is in November. That's all I have.
Great. Questions for Bianca? Hearing none, I want to thank you for serving as our chair on that committee. Bianca, I know they really get granular and detailed. I've listened in a number of times and it's really important and you're just perfect for that. So thank you. We're now going to transition to, this is tab 6, Dr. Judy Zerzan. She is our chair of the Primary Care Committee, and she's returning to provide additional information to the board regarding the committee's recommendations for the board's consideration and vote. As a background, we established the advisory committee on primary care to develop recommendations for consideration by the board, including defining and measuring primary care spending and providing recommendations related to the board's legislative assignment to create recommendations to increase primary care expenditures to the 12% target. Primary care is often the first point of contact in healthcare system, and optimizing this area can lead to improved care and reduced costs. And we need to carefully consider these recommendations as they hold the potential to make a meaningful difference here in our state. And no one better than Dr. Z, who's been working on this primary care issue probably now for a decade and a half, nationally and here in Washington. So tab 6, primary care. Judy, over to you.
Excellent. Good to see everyone again. And next slide, please. Sue actually talked about this, so I am gonna move along to the next slide. At our last meeting, the advisory committee came with this recommendation, a sort of package of strategies to increase the primary care expenditure ratio. The first two, increasing primary care expenditures and increasing Medicaid reimbursement, were policy recommendations that require legislative action. And the last 5 are things that are already underway in some form. And we thought it would be helpful to that effort for the committee to endorse those strategies to be ongoing. And they can be implemented without further legislative action. So next slide. Our first recommendation was to increase the primary care expenditure ratio. And the committee recommended that the legislature establish a goal to increase primary care spending by 2 percentage points per year until Washington achieves the goal of 12%. Also under this were 2 sub-bullets. One, to ask the Office of the Insurance Commissioner to submit a report to the legislature about how payers will be accountable for achieving those targets beyond publicly reported transparency measures. And then requiring agencies to public report the primary care expenditure ratios of all carriers, which includes ourselves at HCA, but also OIC and the Washington Health Benefit Exchange. Next click. You asked us at the last meeting, how much would a 2% increase cost per year? So the next slide. So I wanted to take us back a step to think about what makes up the primary care expenditure ratio target. So the ratio is includes the numerator of primary care spend, so how many dollars are spent on primary care services, and the denominator is total spend. So and spend, as a reminder, is price times utilization. So there are 2 ways to do that. The first is to increase the numerator, and the denominator stays the same. So that would be increasing the primary care spend, but leaving total spend the same. I know that that part of leaving total spend the same is challenging, and that is something that you as a committee are working on, controlling that denominator's growth. The second way is to decrease the non-primary care spend. So the numerator stays the same, but the denominator decreases. And I think in all of this, when thinking about which way or how the ratio changes, I think it's important to say we're not talking about adding more pie, but we're talking about adding perhaps more money to the slice of pie that is primary care. So next slide. So we are going to give you a rough estimate of what it will cost to make that 2% increase. And in order to do this within the time frame, there are a lot of assumptions. So we assumed that the denominator, the total spend, would remain constant as primary care spend increases. We know that that's probably not true, but just as an estimate. Because to get a little bit more precise would require some actuarial modeling and some more time. Second, we want to point out that there isn't a perfect data source for all of Washington. This estimate that I'm going to give you uses the Washington All-Payer Claims Database, which includes some commercial, Medicare Advantage, Medicaid plans, doesn't include self-funded plans, and it uses the older Office of Financial Management primary care definitions, not the newly improved ones from the advisory committee. And then finally, the cost of the increase we are assuming would be spread throughout the system. So it wouldn't just be the legislature adding more money to Medicaid, for example, which would be recommendation number 2, but there would be cost implications across taxpayers, both at the federal and state level, employers and consumers, if there was an increase. So in 2022, the primary care expenditure ratio across Washington state was 4.2%. And if it was increased by 2%, there would be an additional $635 million in primary care spend spread across commercial, Medicare, Medicaid, all sources of healthcare. If instead there was an increase of 1%, so increasing it to 5.2%, there would be an additional $317.5 million in primary care spend. I also want to call your attention to the numbers in the primary care expenditure ratio. So in 2022, the numerator of primary care spend is 1.33 billion in this estimate. And then denominator, the total spend is almost $32 billion. So taken in context, while these initially seem like very large numbers, overall, they are shifting a small part of the pie. Next slide, please. So increasing primary care expenditures may lead to total cost of care decreases depending on how it's done. Better access to primary care certainly can prevent the need for more expensive specialty care or acute care, particularly looking at emergency department visits that could be avoided or hospitalizations that could be avoided. And there's been a number of both state and federal program evaluations that primary care investment can lead to overall decreases in spending. Second, increased primary care spend can increase the total cost of care while promoting improved health outcomes because better access to primary care may increase the use of needed specialty care and needed acute care when the primary care provider identifies conditions that need additional treatment. And this increased utilization is appropriate and does improve overall health. So the context, content, and timing of increasing the primary care utilization are critical to determining the effect on the overall ratio. In other words, it's complicated. Next slide. So this is a time for a vote. So we recommend these policies, which require legislative action, to increase the primary care expenditure ratio by 2 points annually until Washington achieves our goal of 12%. You could, as a committee, decide to make that 1%. That was where the committee started, and they felt like 2% was a better goal because primary care is in trouble. And then the second policy is to increase Medicaid reimbursement for primary care to no less than 100% of Medicare by 2028. I will call your attention on the OFM website where our decision packages live, that we have submitted a decision package to increase the Medicaid reimbursement for primary care to Medicare. So that is potentially in line if you approve to move this ahead. And then finally, voting to endorse these strategies of multi-payer alignment, patient engagement, workforce development, the use of alternative payment models and value-based payment, and measuring the primary care expenditures. Are there any questions?
Eileen.
So Judy, one of the questions that I had when you were just going through this is, what's the ratio of primary care doctors to specialists? To know how, you know,
Oh, that is a good question. I do not know that off the top of my head.
because I would think, well, I mean, I would think that the number is greater, but I don't know. It'd be interesting to know that.
The number of primary care or the number of specialists?
Well, the ratio, I guess, is really that. Yeah, I
Oh,
know
yeah.
that the University of Washington for years was doing a great job of turning out more primary care, not so much in the last 20 years, but, so I'm just curious as to how it, when we look at the expenditure, you kind of got to know,
Right.
yeah.
How many
So,
people are there? I think it's
right.
also hard to know. And we ran into this when we worked with OFM to do that initial primary care spend. It's really hard to figure out nurse practitioners
Yeah.
and really, really hard to figure out physician assistants in determining where they work and they move. So that will remain a challenge to figure out that ratio. We had to make some assumptions ultimately with that OFM report. It is a good question, and yeah, I just don't know it.
Okay. All right. Thanks.
Edwin.
Thank you. I had two questions if I could. The first is kind of unpacking your math a little bit. Would I don't know, make a statement. I was wondering if you could maybe agree with this or not. Because your calculations of the prior slides are assuming the denominator are constant. So those expected cost estimates that you generated, would you agree that those would be kind of lower bounds because you are holding the denominator constant?
Um,
Inaccurate
they
statement?
yes. They could be lower bounds. It's sort of, again, hard to say because we have really refined the primary care spend with that newer definition, and this is using the older definition. So I don't know. I feel like this is a really super back of the napkin estimate.
Sure.
I don't want to like add a lot of weight of like, yes, it could be more. I think probably the bottom line is that if the denominator is increasing a lot,
Mhm.
then it will definitely need to be more than that. If the denominator grows more slowly, then it could be about right.
Okay. That sort of leads me to my second question. I think one of your subsequent slides seemed to suggest, or maybe even stated directly, that investments in primary care, at least in the short run, could lead to cost savings in the medium to long run. I wonder if I'm interpreting that correctly. And if so, do you have any estimates or any kind of evidence from some of the literature that you might be able to cite that kind of gives a more precise number?
That is a great question. I do not, and I will say the estimates have been there's a lot of variables, so it sort of depends on what happens. I think the two places that more and better primary care absolutely do impact is ER visits and avoidable hospitalizations. So, to the extent, and those vary by market. I don't have a good sense of like what Washington's is compared to another state, but there probably is something there. I should also say that cost savings may not be the right word, but cost avoidance is probably a better word. Um, in healthcare, we've all seen, as well as in other places with inflation and over time, increases happen. So it's, not a perfect estimate to say this is going to be held constant and these things will happen. It's complicated, but I think there probably is some cost avoidance to be made by doing this.
Perfect. Yeah, there's a lot of moving pieces for sure.
Yes.
Thank you.
Bianca, and then we're going to finish up with Kim, and I think, need to look at a motion. So go ahead, Bianca.
Yeah, thank you so much for that presentation, Judy. I can say just briefly, based on a report that our Center for Health Workforce Studies did, that just answers Eileen's question. About 35% of the physicians in the state of Washington are primary care physicians. At least that was in 2022. Now, in terms of just point number one, I think maybe I missed this, but so where are we expecting the money to come from to increase that 2%? And how do we prioritize where that money is going?
Yes. So that is a great question. And I think how other states have gone about it is some of it they've left up to the carriers of how do you want to change the money around and what does that look like? So do you add, and one piece that we don't know is what the non-code base, the non-utilization spend is, because certainly there are quality payments that go to primary care. There are different incentives. There's sometimes care coordination money that goes to primary care. And so I think some of that money could be shifted from different places. There's a lot of different places. So as maybe one example, a carrier has been doing some care management, and instead they give some of that money to some primary care practices that are large enough to use that money to do their own care management. And so then that would change some of the sort of the money in the system to be spent in a different way. And I think some of it's a little bit of a chicken or an egg, especially the avoidable ER visits or avoidable urgent care, which can be more expensive. That doesn't happen in a one-to-one switch, but over time, if you have avoidable ER visits and hospitalizations, then that sort of saved money can be moved into primary care. So it depends. I will say 2 percentage points may be a little bit aggressive, but I also think that it represents kind of the feeling of primary care providers in practice that there really needs to be some change in this area.
And just to be clear, I'm sorry, as a follow-up, so this really is relying on the entities that exist already out there to shift money around. So that works for those who already are tied with primary care clinics where they have money to shift to primary care, say versus say a standalone primary care clinic that is not attached to anything where money can go to them, right? Like if there's like
well, in the sense that there's sort of a larger pot of money that a carrier spends. If you don't spend it over here, you could spend it over there. I will say that the other two states that have been at this for a while, Rhode Island and Oregon, have been pretty successful in moving the needle by just saying, increase the expenditure and not being super directive about how that happens, and being super directive about the measurement and about reporting the measurement and sort of requiring that to change, which is part of why some of recommendation 1 includes sub-bullets for the Office of the Insurance Commissioner to measure it and to develop what are sort of the carrots and sticks to help people get there.
Final question, Kim, and I'm going to move us along. Go ahead, Kim.
Thank you. I'm trying to think through a dynamic in my mind. And so if you can help me now with this, that's great. If it needs to be tabled, that's fine as well. So the dynamic that I'm grappling with is that given that total spend has been increasing year over year, and that in fact we've even set the benchmark for cost growth at 3.2%, 3%, et cetera. Essentially, the pie is getting bigger. The total spend is getting bigger. And so to achieve, sort of the 2%, 2%, 2% annually to get to 12%, we're chasing, we're having to spend more than, we're having to increase more, to equal to get to 12%. So so there is this. So my fear, I guess, what I'm concerned is that, oh gosh, we're sort of spending more on primary care, which is very which we all understand why, that we're attempting this and aiming here. But I'm kind of grappling with the dynamic that feels, I don't want to say inevitable, but it does feel distinctly possible and likely that we're spending more. It's going to kind of work. There's this weird dynamic with the total spend growing year over year, and then trying to spend more of the pie, the proportion on primary care. And so I have this sense of more, that there's just sort of going to be more spending. And I need to think about this more, but it's just a little disconcerting to think about 2% per year when we don't have spending under control.
And Kim, if I can just kind of lean in
Yeah,
a little bit, I think we're not looking at doing this singularly. I mean, this would be, wouldn't be in a vacuum. This would be part of the other suite of things. It would be in line with the overall cost growth containment work of the board. So this is one strategy that many states have put in their complement of things that they're doing to drive towards greater affordability.
Yes.
So I like to liken it to thinking about we're kind of encouraging more redistribution of existing services. Now, if Judy is successful with the decision package to bring Medicaid rates up to Medicare, that would create more, but there are offsets, as she has pointed out, in keeping people healthier out of, the ERs or whatnot. But
yeah, true.
Yeah. So maybe Judy, you can follow up with Kim later as well.
Yeah. No, I do think that there are ways, and if most of the growth is going into primary care, then I think overall that longer term trajectory will be improved. And certainly that is what Rhode Island and Oregon have found.
Yeah. All right. And Liz is just reminding us that Oregon has found for every dollar in primary care, it saves 12. And that is pulled, I think, off their all payer claims database. And I know there have been many other articles quantifying that numerator denominator challenge. So I want to see if there is a motion.
So we have some individuals in the room, some board members in the room with their hands raised.
Oh, I'm sorry. Thank you for pointing that out.
I have Ingrid and Jane with their hands raised.
Go ahead. I'm not sure who was first.
Hi, thank you, Sue. Sorry, we're having a little internet or connectivity problem, so you can't see our faces, but
yes, we can now.
Okay. Oh, good. Okay. Hello, everybody. Again, Ingrid Ulrich, Health Benefit Exchange. I think a critical concept here is shift, not increase. So I appreciate other people's comments on that. Even maybe reframing the recommendation around increasing the primary care ratio without further contributing to cost growth, and just really calling that out. I think that what is more important than the how, and that I'm seeing in the recommendation a proposal for transparency in the report that the OIC would do, and then a recommendation around addressing Medicaid reimbursement for primary care. I just have a question about that. Could we be reminded, it's our understanding Medicaid reimbursement for primary care is approximately 65% of Medicare, but could we get an accurate read on that? And then would it require, the other kind of related question is, would it require legislative authority to change Medicaid reimbursement for primary care? Or does HCA have the authority to do that? Or if HCA did, would you need to reduce reimbursement on other services? So just kind of a technical understanding. And in terms of the timing, Dr. Zerzan, I heard you say several times some caution about 2%, that while it's aspirational, that a lot of the strategies to get there will be challenging and will take time across the system. So from growing, transforming from 4.2% of spend on primary care to 12%. Is that that would appear to be about a 4-year time frame I guess my question back to you is like, knowing all the tools in the toolbox to try to nudge that forward and make it happen, the strategies, is it possible? And is that a realistic time frame, or because you indicated some caution there and I just wanted to hear more.
Yes. So for your first question, yes, we need legislative budget authority to change reimbursement. And that's why we have a decision package to increase Medicaid reimbursement for primary care. And we are around 65% of Medicare right now. So there is a way to go. Although I will say in January, there's a 2% increase that's coming because of part of our 1115 waiver. There's some requirement to slowly increase that. The second piece, it just went out of my head. Of how to do it. Yeah.
Also
so
the timing.
I think some of my caution is twofold. I'm hearing your caution of like, 2 percentage points sounds like a lot. And so I'm giving you the option that if it sounds like a lot to you, you could go to 1%. I do feel strongly we should do at least 1%. Also, no other state has done 2%. So I don't know how realistic it is that we would get there. I like being a trailblazer and seeing if we can do it. But I think I'm not sure if it'll be realistic or not. Finally, the third piece I'll say is that we do not have a sense for what that non-claims based primary care spend is, which includes quality incentive payments and sometimes other value-based payments. And so we may be closer to that 12% than we thought, but we won't have those numbers until next year. And so I also think a reasonable strategy could be to start with 1% this year. If we don't, if it turns out that our next measurement is quite a bit bigger, maybe that's okay to stay on 1%. Alternatively, you could say we want to come out strong and let's say 2 percentage points. And if it turns out next year that we've gained like maybe 4 compared to that last measurement by including the non-claims based spend, then maybe we could slow it down to 1%. So I think it's hard to know what that right number is, but somewhere in the range of 1 to 2% increase, I think is a reasonable thing to move forward.
Jane, and then we really need to move forward.
Okay, I just wanted a response to the idea of adding that the legislature established a goal and then stating that it's specifically without impact to cost growth. That was just a specific addition to this language.
Thank you for that, Ingrid. That note of caution.
Yeah. So a couple of things. I mean, I agree the 2% is pretty ambitious. So one option is to say there would be a goal of up to 2%, but a minimum expectation of 1%, right? You can do something like that. But the other thing is, I think if the board is going to endorse this, that accompanying the recommendation would be some information about the experience that Oregon and Rhode Island have had, and a little bit more information about how they designed their approach and what the results have been. Also, I think it would be really important to sort of reference along with this, what kinds of reporting are we talking about, right? Are we going to be looking at claims data to see what happens with utilization of ED services or inpatient admissions? What kind of quality reporting are we going to need? And then also, I know, Judy, there's been some discussion about looking at per capita expenditures versus total spend. And I think it's worth it to spend some time thinking about which is kind of a better measure. And then on the non-claims-based payments, I mean, this is a discussion that we've been having in multiple settings, including the Data Advisory Committee, about the fact that we don't have non-claims payments in the APCD, and that a number of other states are working with the National Association for Health Data Organizations to try to standardize how we collect that information and get it into our APCDs. So I just think it's, how do we substantively goal of 2, minimum 1, but then filling out what goes along with the recommendation.
Yes, so we definitely have a lot more information about Rhode Island and Oregon, and we've talked about that in the committee about some of the how do we get there. And I think we did put some of the non-claims based ask into our data call for this so that we could calculate that and start to figure it out. So I think some of this could be figured out. Either there could be, you know, a recommendation that we need to figure out the how as part of the legislation that could happen, and we have that conversation next session. Also, while the per capita number is appealing, and it is what Rhode Island wishes they had done, there isn't a state that's done that yet. And so I think that would take a lot more time to sort out. And I think one of the things that the committee would definitely say is that we need to start working on this now. And so I think we could look at the per capita costs in parallel, but we should work on this more traditional measure for right now.
Great. Thank you for that, Judy. Board members, it's clear that this is a high priority area. It's one of our tactics. I am encouraging someone to make a motion about moving this issue forward, because I think we would be remiss not to have this in our recommendations in our report prior to the end of the year. And I know, Dr. Z, you and your committee have continued to work on this and continued to evolve it. So I would ask, is there a motion to move this forward?
So Sue, can I do a motion with the friendly amendment of
Absolutely.
the 2% goal with a 1% minimum?
Yes. So Jane, I hear you making a motion that we recommend these policies with the friendly amendment of the goal is up to 2% with a 1% minimum.
Yeah.
Second.
So we've got a motion, we've got a second. Is there further discussion? All those in favor say aye.
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 And are there any opposed? All right, if not, the motion is approved. And Dr. Z, I know you'll be getting back to us with some refinements about measurement, and we're wishing you the best with that decision package and keep moving this primary care work forward.
Great, thank you.
All right, thanks so much. Okay, if people will scroll to tab 7, Janine Smith from Health Management Associates is next up. I know we've got David Auerbach, our Senior Director of Research from Massachusetts Health Policy Commission, and Vishal Chowdhury, our Chief Data Officer from the Healthcare Authority. They're going to talk about facility fees, and they're going to get us more information for our discussion on this topic, because we hope that this is another lever that we will be able to pull over time, and we need to continue to examine it and develop the recommendation. So welcome back, Janine. You're going to start us off, and then I think you're going to introduce the other presenters.
Correct.
Great. Over to you.
So Janine Smith from Health Management Associates, if you want to move to the next slide, just give a real brief recap. I know we talked about this at past meetings, but facility fees are the issue of, and whether that is contributing to increased costs. And as consolidation has increased, there has been an increase in the use of them. Washington State's collected quite a bit based off of 2022 data, and it has had an impact. There is some reporting about it to DOH as part of year-end financials, but pretty limited, as we talked about before, and not always sure exactly which services get them, which entities exactly, and the quantifying it per the consumer has been challenging. Next slide. So advance notice is the other aspect of facility fees, and there is some requirements regarding noticing of this and posting predominantly, but it's not required for some places that charge facility fees, such as x-rays, testing, therapy, pharmacy, or educational services, and if you're a designated rural health clinic. And ambulatory surgical centers are not required. Next slide. So the recommendations we're going to hopefully get a chance to talk about today, although we do have some limited time, is to think about whether there's need for more transparency about the data itself as to who's charging them, and could that be integrated into ABCD, as you will hear Massachusetts talk about their experience there. And also, the who owns what. It kind of touches on the other aspects of mergers and acquisitions that this board's been discussing in the past. And then is there further reporting that needs to be obtained? Now, you asked when we presented last time a little bit about what others were doing. So I'll give a brief overview of that, but I'll certainly let Massachusetts talk about themselves. Next slide. Colorado requires every off-campus location of a hospital to obtain an MPI number, which is kind of a unique identifier that allows you to pull it out of the claims data better. Massachusetts has a provider registry. Again, let them talk about that here in a minute. And then federal lawmakers and other states are considering similar proposals. So the provider transparency is something that Washington State might want to think about to get a little more information about this and better understand the extent and capacity of this as a contributor to healthcare costs. Next slide. Eliminating fees is another approach that other states, Connecticut, Indiana, and Maine, have begun to move in this direction. It allows some less intensity for the patients being charged different types of cost sharing, and could potentially have some challenges in terms of leading to increases in other fees or to offset that if you were to eliminate the facility fees, not necessarily in general, but there may be some services that could be without a fee because they don't necessarily require, versus a procedure you might have in a clinic is a lot more overhead, or a hospital, versus just doing an x-ray or just doing something. And just because they're sitting in a hospital owned facility, they get charged a facility fee. So it really is sort of being selective about eliminating fees for some procedures. And as Massachusetts will talk about, that they have recommended that be for things like lab tests, imaging, and some of the diagnostic services, and a physician visit that just happens to be in a hospital-owned facility. MedPAC, which is the Medicare Payment Advisory Committee, and it's more of that on the future slide here, has recommended certain services and codes that could be potentially not have a facility fee. Next slide. Connecticut has started to prohibit fees for evaluation and management services. So those are like, when a doc sees a patient, if they're on an off-campus location. They have extended this starting just this summer to on campus. They exclude emergency departments, which has been the concern that, you know, these fees are important for the sustainability of the emergency department. So it's really just focused adjustments to the facility fee on when you can charge a facility fee and when you can't. They bar health care providers from collecting more than the insurer contracted facility fee rate when consumers have not met their deductible. There's more consumer disclosure requirements in Connecticut, and there's a lot of more annual reporting on the fee data itself. Next slide. Then there has been a lot of work, especially at the federal level, to talk about site neutral payment caps. They prohibit certain fees from being charged, and they cap the reimbursement for those services with the intent of trying to keep the so that they're at a percentage of the Medicare rates or the median price the insurers would pay independent physician offices in the same area. So it just because you're in a hospital-owned facility versus a private practice facility, you shouldn't necessarily be charged if it's a safe procedure that it doesn't necessarily have to be done in a hospital setting and need more support, which necessitates the higher facility fee. Next slide. MedPAC has done some extensive work on this, and their June 2023 recommendations have details about this. They think that if it's a safe and appropriate to provide the service in different settings, Medicare should not pay more for that service in one setting than another. And they have looked at specific codes. It's pretty detailed, but there's certain clinic visits, some drug administration, some imaging services, other procedures and diagnostic tests and pathology services that they don't feel need to have a different fee applied, but should be neutral to the site. They have also examined in their detailed report, which is in the references that are in part of your meeting packet, in terms of what that impact would be on rural versus other hospitals, and it's fairly extensive evaluation before they made this recommendation. So with that, I'm going to turn over to David Auerbach from the Massachusetts Health Policy Commission to talk about what they're doing in Massachusetts. David, are you on?
Yes, I'm here. Can you hear me?
Yes, go ahead.
Okay. Thank you. Thank you. It's great to be here talking with this group. I recognize Bianca Frogner from many past lives. Thank you very much. And I'll just say for this presentation, so I'm the Director of Research. This presentation is going to be a little more on the side of data and background and a little bit less of the policy, but that was a great discussion, and it overlaps somewhat with what you just presented. So hopefully it'll be still helpful and add some value. Okay, so and we presented this last year as part of a discussion of this same topic, and I'll end with a recommendation that we've made as part of our policy recommendations. I'm starting out just giving, at least in Massachusetts, the sort of the lay of the land of some of these same services that we keep talking about that really are not qualitatively different, whether they're provided in a hospital setting or an office setting. And this is just a share of where these are provided in Massachusetts. The HOPD is the hospital outpatient, and we love our HOPDs in Massachusetts and provide way too many services in those locations. And you can see these are all majority in the hospital outpatient department. Okay, on the next slide. And then some of this background that we've already covered. Payers typically pay more when the service is provided in a hospital site. The payment includes a professional component and a facility component. And it's not always the case that the facility fee is just an add-on and the professional is the same wherever the service might be. Sometimes the professional part is smaller, the facility part is bigger. So you really have to think of the total amount being paid. And of course, in the commercial market, these prices are reflecting market leverage in addition to other stuff like costs. And the tradition, I'm sure, has come from, the assumption that in the hospital, you have a lot of higher complexity, higher intensive patients that need all this infrastructure around them. And in an emergency department, sure. But again, this that price differential has been extended to a lot of things that are really the same service in both places. And we talked a little bit about MedPAC, and I'll note that Medicare does pay site neutrally for some things, administered drugs, labs, mammography, and some E&M visits. But we find that our private insurers, even in those cases where Medicare is paying site neutral, our private insurers are paying a differential. And that probably just arises from tradition and just from the leverage that hospitals have to obtain higher prices for services that the payers often have no answer to. Okay, so on the next, let's move to the next one. And of course, I'll just add on the MedPAC recommendation. Another way they think about this is, for a given service, does it make sense to pay this on a site neutral basis? And they'll sometimes, some of the recommendations will say, well, is a substantial amount of this done in the office today, like a quarter or a half? Is there a significant, proportion of that service being provided in the office? That is telling us that yes, it's probably safe to provide there, rather than trying to find some kind of safety or outcome data. They'll usually just go by, is it happening in the office right now? Okay, that's a signal that it's probably fine. And so on this slide, yes, we've also covered that it's not just that the insurers are paying more, but the out-of-pocket, the cost sharing typically follows that. So patients are paying more. And if another implication of this, something else that happens is, because of those higher payments in the hospital setting, it's another incentive for hospitals and physician practices to consolidate, vertical integration. Hospitals can buy those physician practices and then charge the additional fee for the same thing. So it does lead to consolidation to capture those higher revenues. Okay, let's move on. So what we show in the next few slides is really just to give people a sense of how big are these differentials. What are we talking in terms of the price differences? And again, this is from Massachusetts, but it's probably similar everywhere. So we're going to compare a few things. Here is the price of a basic lipid panel. You can see the Medicare price, $13 on the top. If we see this done in an independent third-party lab, on average, it's about $14. In an office setting, $17. And in a hospital outpatient department, we see an average of $30 with a 95th percentile of $73. So it's about double the price. And on the next slide, another example, what we've done is we've created a lab price index where we've grouped together the 50 most common labs, and we just wanted to compare how much are our insurers paying for this market basket of labs based on where they happen. And all those blue bars are different hospitals. You can see there's variation across the hospitals, which is reflecting their leverage, but all the blues are higher than all the yellows, which are independent labs, and all the reds, which are office locations. And the bottom portion of these bars are showing the cost sharing, which the patients pay, and it's kind of proportional to the total price. So again, just more background. And Medicare's price is that gray hashed bar across the horizontal there. Okay, next slide. And now we went to an example of an abdominal CT scan. This is a case where Medicare does pay a differential. You can see Medicare on the top. Their office price is about $400, and in Massachusetts, our office price was $830. And then on the bottom is Medicare's HOPD price, $524, and our commercial HOPD price was $1,300. So even a bigger differential than Medicare has. So really, you just see this big widening gulf. Okay, and then I think there's maybe one or two more. Yeah, we then went to a clinician-administered drug, Neulasta. You can see what Medicare pays and the office price, about the same. Medicare doesn't pay a different price by setting for administered drugs. And then in the HOPD, it's double in Massachusetts. So just to show our policy recommendation, given this and everything we know, we recommended our 9 recommendations in our last year's cost trends report are listed there on the left. And I'm just pointing out number 2 about constraining excessive provider prices. And under this, we wanted to limit prices that were too high, using sort of a Medicare benchmark, but it's not in great detail there. But we also, as a sub-recommendation, We recommended that we require site neutral payment for these services, and also an out-of-network default payment rate, given how well the No Surprises Act seems to be working. So these are some of our recommendations. And it's true, on the previous speaker noted that transparency is a bit less of an issue for us. We do know who the providers are and where they are with a special provision of our law, but it doesn't really end up preventing some of these excessive pricing.
So I think we were going to move to Vishal Chaudhry to talk about Washington. Thanks, David. That was great.
Can I ask a question to David? Is that okay?
Sure. Go ahead.
So can we go back a slide? David, the reference to limiting excessive provider prices.
Yes.
Is that, how does that relate to the facility fee issue, or is that a distinct proposal?
It is related. I can forward you our cost trends report last year. We recommend that, well, in that report, we showed across an array of services the total price paid by commercial payers compared to what Medicare pays.
Right.
All in. And recommending that anything over 200 or even more than that is probably an excessive price, is more than the provider needs, is more than the market should be paying. And so in a lot of cases, these happen to be hospital outpatient services with a facility fee and a professional fee. And so we take the total payment, we combine those and say, that's the price. Here's what Medicare would pay. And in cases where that total is more than double that Medicare total, we recommend limiting that. Now, we were not as specific as to say, thou shalt set a line at 200, which is what Oregon does for the state employees program, which I think we've seen a lot of research on that, of course, and I'm sure you're familiar with that. But we did a lot of modeling and data around what if one were to use that as a benchmark. So it's related, but this recommendation is a bit broader on the prices.
So the provider prices that you're limiting are not just those that you want to apply site neutral payment to?
Not just those. It could be even an example of just a physician, bill for removing sutures, whatever it is.
Got it.
And, yeah.
Okay, thanks.
Other questions for David before we switch over to Vishal? Vishal, did you?
Not a question, but David, great visuals, and really appreciate the refresh on this issue.
Sue, I think we're handing it back to HMA with Janine.
Yeah.
Yeah. So Vishal, I think, was going to present.
Janine, I don't have any slides. I was
okay. That's fine.
Have to answer any questions or provide the perspective from the APCD as to what we can get out of the APCD or not, and how much granularity. So if there are questions about that, I'm happy to answer. But would second all of what David already said. At the end of the day, the facility fee component, especially on the commercial side, when we start picking hair in the APCD data, we run into a wall. Primarily because even though Medicare and Medicaid, there are stipulations around separately calling out facility fees, not all commercial contracts have that because they don't need to. Their negotiation practices are different. Their drivers are different. So looking at a reference overall and looking at the affordability of the overall cost or pricing is probably a better health policy approach than just focusing on only the facility fee component. That's what I would say. I don't know, David, if you have any thoughts on that.
Yes, I agree. One should look at the total payment, and that's really what's relevant.
So I see your hand up. Oh, Margaret, you're muted.
Thank you. as I think about this, I think facility fees are a pretty annoying concept, and I can see why we want to go after them. But I'm thinking about whether a hospital or another facility is making or losing money, and it feels like we're picking at a certain part of their total billing and saying we ought to reform that. And yet they need to at least break even overall. So it seems like they're likely to make up the loss of the facility fee somewhere else because they need to in order to survive. So that's the issue that's kind of plaguing me.
Eileen, you had your hand up.
Yeah. Margaret, I just have to like jump in because as they were doing the presentation, I remember when we had the first discussion about facility fees in the legislature and the bill that we did pass that it requires the reporting that we have now, which is, and God, I think it was 10 years ago. And I thought about this when Bill was speaking about facility fees because he mentioned Yakima. And that's where our bill came out of. And I remember it was Representative Norm Johnson's bill because a doctor's practice in Yakima got purchased by one of the hospitals. I don't remember which one it was. At that, they had two at that time. And they made $1 million in a year off of that practice. And so from my perspective, I always thought the facility fees were supposed to be, as you say, paying for the hospital or paying because of the bigger overhead. And when they buy something that's already built and in place, it never made sense to me that there was a facility fee then. So, I mean, I think that's where the problem is, that there's just not a lot of logic behind where the facility fees get charged and how much. And
Right.
that's the thing that we have to try and wrestle with.
I like the idea of working with the Alliance as a joint effort to try to figure out where it's appropriate and where it isn't, taking into account all the efforts that are going on nationally and in Medicare and so on.
Vishal, were you going to add something?
Yeah, just wanted to respond to that and also the comment from Seattle Children about, opening satellite offices so the communities can be served. The facility fee as a concept was, I think, Janine, you mentioned that, to account for the wraparound services that are part of a hospital setting that may not have a way to be reimbursed appropriately because, of well-known reasons. But when a separate satellite facility is opened up, the cost basis for that facility is inherently different than that of a hospital campus. So to use the logic that just because it's part of a larger organization, the billing basis should remain the same, even though the cost basis is different, it doesn't pass muster from an economics perspective. From a business and profit margin perspective, yes, of course, it makes sense, right? So those are the perspectives that I just thought I would share. Thanks.
Sue, I'm not seeing any other questions. Are you?
I'm not. Jane, did you want to jump in? I thought I saw the camera pick up your hand.
Nope.
Okay. All right. Well, I really appreciate the additional information. And again, I remind the board that we have been grappling with this issue and we are, we're under a timeline. We've got to issue a report by the end of the year with recommendations. We continue to get consumers and the industries kind of suggesting that, we've got a lot of data. We've got a lot of angst about the data. I think it's a process as we've journeyed through this, but I think we need to seriously consider moving some of these recommendations forward. So I ask the board, how are people feeling at this point about making some recommendations about facility fees, especially in light that MedPAC has pushed forward recommendations, and we know from our neighboring states and some of the actions that are being taken with other cost boards that this is an area that is ripe for activity and scrutiny and better understanding. So what is the pleasure of the board at this point? Jody, I see your hand up.
Yeah, one thing I'm not sure came up today, but did come up the last time is that one of the challenges around these facilities fees is that sometimes they're not eligible for any type of reimbursement. And so patients can pay twice for a service, and they may have to pay a complete charge instead of a copay for this facility fee. And so I think as we continue to center the resident of Washington State and what these facility fees mean for them, I think we need to keep that in mind too.
Yeah, thank you for that comment, Jody. And I think David was showing us that too with the copay portion of his graph that he had. Other thoughts or comments, or does somebody want to make a motion?
So we do have comments in the room, and the slides do summarize some of the recommendations if you want to move forward to the next slide.
Yep.
Ingrid has
Yep.
Oh, thank you, Michelle. And I think Ingrid or Jane, were you wanting to jump in?
Yeah, thanks, Sue. Thank you, Director Birch. I want to build on the comments we already heard and say, Margaret, I heard you say that facility fees are annoying. I think they are. I think consumers get pretty astounded when they receive these bills. They don't make sense, or as is it Jody that you just said, they're then having to pay twice. So there's a lot of precedence for this as a cost driver. It doesn't make sense to people, and it makes people angry. And as Noam Levy put it when we heard many of us heard him in Nashville, it's the damn bill. It's about the damn bill. And for those of you who heard him, it is about centering the consumer experience. So I think that we've got 4 recommendations on the table. The first 2 seem very sensible in terms of just collecting some information that's missing. And that's number 1. Number 2, just creating some building blocks of data and information that we don't have that could be useful for many reasons to understand the landscape of who owns what and how that is rapidly changing, and be able to track on it in a logical manner to do also more broadly monitor the impacts of mergers, acquisitions, and private equity. 3 and 4, maybe just progressing a slide. These also, I understand the intent. There's a little more questions here, maybe a little more staff work needed on how would this be enforced? Would there be any unintended consequences, or would it create a game of whack-a-mole, if you will? So I think that this is one of many approaches or recommendations that the board should make. Facility fees is one issue among many, and it alone, of course, won't get us very far in the broader goal of meeting the cost growth target. But it is important. I think it's important for consumers.
Thank you for that, Ingrid. So are you recommending, are you making a motion that the board adopt all 4 recommendations at this point, or were you just?
I think the board should now just speak more with specifically about all 4. We're feeling super from where I sit at Wabi. We feel very comfortable with 1 and 2, and with 3 and 4. There was probably going to be more detailed staff work around those to ensure that they could be designed in a way that would work for Washington.
Thank you for that.
So, so on recommendation number 2, I'm thinking about a friendly amendment because we've had discussions, I think several discussions about the lack of ownership and affiliation information that we have. And our colleagues in Massachusetts have actually put together a pretty extensive system for reporting ownership and affiliation, and have learned from the Steward Healthcare debacle that they probably need to also be requiring reporting by private equity acquisitions. So I'm a little bit concerned about just saying you want to talk about unique NPIs, because there are a lot more services or providers that may be affiliated with a hospital system or a carrier, right? It's both, it's everything, than just the services that we've been talking about today that we're particularly interested in. So I would put forward expanding recommendation 2 to get more at ownership transparency, including not just provider, but also issuer and also private equity. And if you want to table that and have that as a separate discussion, I'm happy to do it. But I think it's really important. I do think that if there are ways that we can modify the data submission guide or require using MPIs so that we're able to get good data about facility fees, that would be super helpful. And it's a discussion that I know I've had with Vishal already. My one concern that I have about recommendation number 3 is acknowledging that and sort of picking up on Margaret's comment, that if you put a box around one set of services and how much you're going to pay, it doesn't prohibit commercial payers negotiations with carriers to sort of move that revenue source to another place in the rate negotiations that go on. We have the luxury of Medicare having a fixed rate that it pays. So for MedPAC, I think it's a little bit different. But for commercial health plans, given how wide open rate negotiation is, I would be a little bit concerned about just saying prohibit facility fee billing in isolation without, as Ingrid talked about, thinking about it in the context of a broader suite of recommendations that the board might make. So I'd be really interested in other thoughts too.
Thank you for that, Jane. I think Bianca might have been next and then Eileen. Yeah. Go ahead, Bianca.
Thank you. This is a great discussion. Personally, I think 1 and 2 I feel comfortable with. I think 3 and 4 I'm feeling somewhat not well informed quite to move forward. But I think 2 things I'm not quite knowing where it fits. One is I think if I remember right, there's some concerns that sometimes people are getting duplicate facility fees or being paid like more than one time for like the same service. It seems like that at least should probably be prohibited somehow. I think the other one is where people are getting charged a facility fee when they're not being cared for in a particular setting. I just recall those 2 being issues. I just don't know where that falls into this picture. And maybe I'm just wrong about those 2 issues. So just wanted to bring that up.
Janine, can you clarify that question from Bianca?
I think there is some in the literature of being charged duplicate fees within a setting that I'll have to go track down the exact information and can look at it further, Bianca, with you. I'm not clear exactly on the issue the second one you just brought up.
I think I recall like sometimes people are cared for in one setting but they're charged based on some other setting, in which case then they're paying some facility fee that's not really associated with where the care actually was. But maybe I'm confusing it with a different topic. Doesn't resonate at all.
Yeah, I'm familiar with that. And I don't know if David's still on, if those guys have run into that as well in Massachusetts, but sometimes you're getting charged the hospital fee at a outpatient procedure because they're owned by the hospital.
I think that's basically
so that was sort of part of the issues with these and why MedPAC and others were looking at site neutral, in the sense that why should you be charged more and Sue brought it up previously, at a facility that just happened to be bought by the hospital and it's miles away from it, but they're charging the fee, even though before that they were doing the same procedure and they weren't charging the fee in the same as high a fee. They weren't charging the hospital facility fee like you would if you were sitting on the hospital campus.
Okay, thank you. I think that clarifies what it is. Okay, I was thinking.
Eileen.
So I just want to kind of let's take a step back and clarify. These are the recommendations that we're trying to put forward to the legislature, correct?
Correct.
Because that means that we still have to go through the legislature, get the legislature to vet these and makes, take action. And you know how they are. So I guess that what I would think is definitely we should basically make a strong recommendation on the first two because we need more data, and encourage them to look at working with the alliance, or how to frame 3 and 4 to move in that direction. But I think they're going to look at the data and try and figure out where things are at. I guess that's what I'm trying to figure out, how to move us forward, but recognize that I know there's going to be requests for more data.
Thanks for that, Eileen. I have to say I'm feeling a little bit the same, that to just do 1 and 2 doesn't feel like we're moving with enough urgency from all the feedback we keep getting, and with all kind of the data that we continue to hear about. And it does feel like we need something a little more actionable in 3 and 4, but that things probably need to be fine-tuned for Washington. And I'm wondering, Janine, and Mandy and Michelle, is there a way for us to refine this and have it come back at our next meeting so that we say we are going to endorse a suite of these recommendations, 1 and 2, although I liked Jane's, I like Jane's friendly amendment on number 2, but that we come back with number 3 and 4 a bit more refined. Do we have that amount of time? Here we sit at the end of September. Is that realistic? Mandy, Michelle, Janine, is that possible that we could have you refine things and bring 3 and 4 back to the board?
I'll defer that to Mandy, who knows the next meeting's agenda. It's in November.
When is the report due?
Eileen made a helpful recommendation that we might be able to pick up in this moment, and then that would move the ball forward with the legislature. So I do think it gives us that time to find more data. So and McCray set up recommendation for the legislature. So we may be able to, Eileen, I know you proposed some language, perhaps. Sue, would you be comfortable with a motion with regards to Eileen's language that we make a recommendation that the legislature investigate this particular facility fees for further action?
Yeah, I'm very comfortable with amendments to these recommendations. Eileen, I don't know if we just want to investigate or if you want to be a little more directive in this recommendation of 3 and 4.
Well, when is the report due? That's the first question.
By the end of the year.
So it's not until the January 1st. So
December 1.
December 1. So we do we can get it, wordsmith, and then at our next meeting, finalize it. That's what I was trying to figure out. Because I agree with Jane with her, getting that added into recommendation 2. And then I think that what we want to do is get basically 3 and 4. I don't know. I mean, either one of those ideas would be moving forward. We just want to encourage the legislature that they need to pay attention to this and figuring out which direction they want to go. I mean, I think that's when we're making the recommendations.
Yeah, and I think to Jane's point, we don't want to see this just be restricted where commercial, get their rates go up more, that it just becomes another squeeze the balloon and it shifts the cost over elsewhere.
Seen that happen a couple times.
Just a couple.
We can work on the language in the meantime for the next meeting.
Great. So I would entertain a motion about this conversation to include elements of all four, but would somebody like to make that motion?
I don't know how to, I mean.
Maybe you guys could roll back through to 1 and 2 and we could outline those and then we could bundle 3 and 4. So could you roll back the slides to recommendation 1 and 2?
I think we're fine with the way language is in 1, correct?
So the motion be to
motion
adopt recommendation number 1.
Then Jane, you're in charge for number 2.
So for recommendation number 2, it would be expanding the scope of recommendation 2 to require ownership reporting across provider systems, carriers, and private equity acquisitions. And certainly include in that the concept of the NPI and a mechanism to be able to identify facility fee claims or facility fee charges in the all-payer claims database.
Thank you for that. And then Mandy, if you'll take us to recommendation 3 and 4 so we can look at wordsmithing those or bundling them in some way.
Well, Margaret, I'm going to ask you. We want to try and get to work with the Health Alliance to identify how to cap the charges, or I don't know whether. I think on site, various site neutrality. I mean, it's kind of like site neutrality. Is that the right words? I don't know how to phrase this one.
Yeah, and I don't know if Drew is still on, but Drew has a subcommittee working on hospital expenditures. And so I really like the idea that Margaret's bringing up of work with the Washington Health Alliance to bring back to this next board meeting a kind of an encapsulation of 3 and 4 that would move us towards more appropriate understanding of the hospital expenditures and pull in the themes of site neutral payments, MedPAC recommendations, and back up to number 3, please. And other recommendations about facility fee billing prohibitions. And I wish Greg had been on because he had some really great ideas about this as well. And he works extensively with Drew at the Washington Health Alliance.
I think that's a good proposal, is to bring it back in November. And in the meantime, staff can work with the Alliance and see where there's common agreement on what should go to the legislature.
Another thing, just Sue, quickly, in terms of the impact on consumers, it would be helpful to understand, and OIC has not gone out and done a data call with the carriers on this. And like Vishal said, it's really difficult to see it in the APCD. But what we don't know is the extent to which, for example, for an office visit, I might have a $40 copay. And if my $40 copay just applies to the professional component, and then I'm on the hook for the entire facility fee, it would be, I think, helpful to try to figure out whether it's looking at plan design or otherwise, how often it is in plan design that the consumers are fully on the hook for the facility fee.
So Jane, are you suggesting we kind of evolve a recommendation 5 that is more specific to the impact of to the client?
Well, I think no matter what we do, we need to be looking at what the specific impact is on consumers. But I think if the idea is we're going to say these are the explicit things that need to be investigated further, or that these are the principles that should govern any thought about a facility fee prohibition, that we would include something like how much do consumers really have to pay in given current plan design in the explicit issues that should be examined. Am I making sense?
Here's
or
a,
am I
here's a
blathering?
legislator to direct the OIC to investigate plan design.
I'm happy to give them, since we have a new commissioner coming.
Here's the med pack principle that it says it really simply is if it's safe and appropriate to provide a service in different settings, payers should not pay more for that service in one setting than another. So that's how MedPAC phrases it. I think in terms of, I just kind of, Sue, I know we're running short on time. It sounds like strong endorsement for recommendation 1, amended language next meeting for recommendation 2, and some kind of combining of 3 and 4 to assess strategies such as facility fee billing prohibitions and site neutral payments to understand, how they could be implemented in Washington State. I mean, something taking that a step further for the next meeting of combining those two and trying to keep it in simple speak. Because people don't know what site neutral payments are, so that MedPAC principle sort of states it more clearly.
I am comfortable with that kind of amalgamated motion of those recommendations. How is there going to be further discussion about that, or do we have a second to that motion?
I'll second it.
Okay. Further discussion? So again, 1 is as proposed, 2 augmented with Jane's recommendations about greater M&A and private equity, and then that staff come back working with HMA on kind of a refined 3 and 4, all under the construct of being consumer minded and also looking hard at the MedPAC recommendation.
And working with the Alliance.
And working with the Alliance. Thank you, Margaret. And that's assuming that they will want to work with us, but they have really stepped up as a partner in this work. All right. So we've got a motion, we've got a second. All in favor say aye.
Aye.
Aye. Aye.
Any opposed? We have a motion approved on facility fees. Thank you all for that important work. All right, I know are running over on time. Are people able to stay over just for a short bit on the OIC presentation? Because I think it's really important. So
I'm sorry, I'm going to have to drop off actually.
Okay, Edwin, we will get you the slides. Jane, if you want to take us into your report, that would be great. This is under tab 8. And again, thank you to Janine Vishal and to David, and that is great work. And we will be back at you with more of the facility fee language. So Jane, over to you, because you're going to give us the report. You're going to give us a skinny report of the final report.
I'm going to give you a skinny report. So I'm going to be like I'm from New York, which I am, and talk really fast. And what we're actually going to do is we're going to skip ahead to slide 10.
We got it all. We are on New York time.
Okay. So if you remember, we had a preliminary report that we put out in December that talked about the degree of horizontal and vertical consolidation and private equity ownership we had in the state. There was a long list of options, about probably 8 or 9 options that were included in that report. And OIC, after consultation with legislators, state agency partners, and stakeholders, and after trying to balance out affordability options that would impact carriers, those that would impact providers, those that would impact premium, those that would impact price, we came up with looking at these 5 policy options. So next slide, please. So the first one was to establish a reinsurance program. And I want to note, Liz, I think we have folks on the line from Wakely if people have any technical questions about the actuarial analysis. They did an awesome job on actuarial analysis. So and we can, next slide, please. So many of you know reinsurance programs. They basically are designed to impact usually the individual market, but also the small group. Next slide. 17 states have reinsurance programs. And essentially what you're doing is you're pulling a chunk of high cost claims out away from the insurers. And you are having those claims paid through a separate system. And generally, and what Wakely modeled was estimating the impact of a reinsurance program that would reduce premiums by 10%. So next slide. And what we see with reinsurance is if you look at 2025 enrollment with and without reinsurance, marginal impact on enrollment, reinsurance dollars, it would cost, and you can see the total amount that would be needed to pay those claims that you pull out. There's a significant opportunity for federal funding here because the feds will allow states through a waiver to essentially capture the federal dollars that are saved by virtue of the premiums being reduced. But the states also have to pay a share. And so you can see here a state cost of between $42 million and $60 million. And the reason there's a big difference is because we know that at this point, the additional ARPA premium subsidies are slated to go away as of 2026, which means the feds are paying out less in subsidies, which has its whole other set of horrible consequences, but also means that it would cost substantially more to do a reinsurance program. Next slide, please. And we looked at it both from over a 5-year period for both the individual and small group market. As you can see, the biggest impediment to this one is if you look at the state funding needed, that's like sort of the annual amount that would be needed and the range of what would be needed each year. So while we would really, really, really love to make health insurance more affordable for small employers that are trying to do the right things, there's a pretty hefty price at the state level. Next slide. And what you will see in the report is for each of the things that we identified, each of the policy options that we went through, you're going to see a slide that looks like this. So we essentially said, if you have those savings in the healthcare, in healthcare expenditures by employees and employers, what does that mean? How many more jobs are you going to create? How many people can shift from part-time to full-time? And how much are people going to save on their premium dollars? And then we looked at the fact that Social Security, Medicare, federal income tax bumps that savings down, but also in addition to those savings, people have additional money in their pocket. And so they spend it on things like housing or tuition for their kids' college. So for example, for reinsurance, over the course of 5 years, there's a net economic impact to the positive of $2.4 million. Next slide. And I think I went through pretty much the reinsurance pros and cons, and I don't know why it's not showing up because it's on my paper. Okay, let's go to the next one. There has been a lot of discussion over the years about whether we should require insurance companies to spend a bigger portion of the premium dollar on actual medical claims that are being paid rather than the minimum that's set under the Affordable Care Act. Next slide. This option would affect all fully insured health plans, so individual, small group, and large group. Next slide. Most of you know that under current law, under the Affordable Care Act, a health plan has to pay at least 80% of the premium dollar for medical care or quality improvement for individual and small group. For large group, it's 85%. So we looked at what would happen if you increase the standard to 88%. And I think the biggest takeaway here is that most of the insurers in Washington state, we asked Wakely to look at data from I think 2019 to 2022 or 2021. And what we found is that most insurers in Washington are either near or at or above the 88% standard. Next slide, please. And so you can see the savings, the aggregate savings are pretty marginal on this because so many of the carriers are already at that 80% medical loss ratio. Next slide. And again, sort of like reinsurance, the total economic impact, about $1.6 billion over 5 years, I can't believe I'm talking about $1.6 billion as being marginal. But when you see some of the other things that we're going to look at, I think that'll put it into context. So let's go to slide 24. And slide 24 is reference-based pricing modeling. So you heard some reference to reference-based pricing in the public comments that were given. Next slide, please. Here's the issue with reference-based pricing. There's 2 ways to design it. One way to design it is to say, we're going to cap the amount that a payer can pay for a service. And under state law and federal law, if you take that approach, you can affect PEB, you can affect SEB, and the fully insured health market. But if instead you say, I'm going to cap the amount that a provider can charge for a service, then you're bringing in self-funded group health plans as well. And just for context, about 1.3 million people get coverage through fully insured health plans, and an additional 2 to 2.5 million people in the state get their coverage through self-employed plans like Greg Marchand's Boeing health plan. Next slide. So essentially, reference-based pricing has been adopted in Oregon for their state employee and school employee program. There's a very recent article in Health Affairs that showed the savings that have accrued from their approach. Montana used this approach for their state employee program for several years. And we actually do it in a mini way in Washington State with respect to our public option plans, where there's an aggregate reimbursement cap of 160% of Medicare across all services that are included in the standard health plan. And essentially, reference-based pricing says, I'm going to establish standard reimbursement rates for a set of healthcare services that are tied to a defined pricing level. And I want to emphasize this here, such as a percentage above what Medicare pays. Reference-based pricing does not mean that you are going to pay what Medicare pays. The entity that's implementing reference-based pricing can choose what they want, where they want to set the price. So let's look at the next slide. We had Wakely run sort of what the variability could be in healthcare spending. It came out, and I'll explain this in a minute, to anywhere from 3% savings to 20% savings. And that has to do with the design of the program. The enrollment impact is, we know when coverage is more affordable, more people get covered. And then in terms of Washingtonians affected, as I indicated, it depends upon whether you say this is what payers can pay or whether you say this is what providers can charge. And I will say this, that the data that I'm going to talk to you about now a little bit is Wakely went in using the all-payer claims database, and they repriced what's currently being paid to express it as a percentage of Medicare. And this is fully insured health plans, this is PEB, and this is SEB. And what we know is that, as we indicated, APCD claims data doesn't include non-claims payments. And also, when we looked at the APCD claims data, it actually looked somewhat lower than what the health insurers submit to us in their individual and small group health plan premium filings. And so what you're going to see looks lower than what RAND and the Washington Health Alliance have put out. And we think part of it is just because of limiting the use to the APCD claims data. But when things were repriced, we used 2022 data just to give you some examples. Primary care providers were at 150% of Medicare, which I think was a little bit better than we thought we were going to see. So this is a good thing. Specialists were at about 144% of Medicare. Hospital ER visits were at 309% of Medicare. Hospital outpatient surgery was at 232% of Medicare. Hospital inpatient surgery was about 200% of Medicare. And this is the thing that caught my attention more than anything else. Mental health and substance abuse professional fees were at 88% of Medicare. They were less than what Medicare pays. And that caught my attention more than anything else. But what this tells you is that reference-based pricing can be used exclusively to save money, but it also can be used to rejigger where the money goes. So for example, if there's a reference-based price that puts some downward pressure on hospital rates, you can take that and you can invest it in, for example, fees, professional fees for mental health therapists, or bumping up and getting to meet that primary care spend increase that we talked about earlier. And just as an example, we had Wakely run what would happen if you repriced everything to 160% of Medicare. You would save in 2022, you would save $455 million, even with spending $200 million more for mental health and substance use disorder professional provider fees. So next slide, please. So then we looked at, again, what could the impact be if you set reference-based pricing at 160% for everybody? And we did it for a single year. So for a single year, you're talking about, in addition to the $455 million that you saved, an additional economic impact of about $320 million. Next slide. And next slide. So there was also reference to hospital global budgeting. Next slide. And hospital global budgeting would have basically, assuming you get a Medicare or Medicaid big fat 1115 waiver, would bring in everybody but essentially the military folks and the uninsured folks. And as was indicated, next slide in the comments, Maryland is the only state that's implemented a model. And we do know that how can I say this? I acknowledge the statement that was made about Maryland's cost base at the beginning being higher than Washington's cost base might be. But we did go ahead and flip to the next slide, please, and model hospital global budgeting, assuming that the rate of increase was the board's cost growth target. We did not include in this model critical access hospitals, psych hospitals, rehab hospitals, or children's hospitals. And one of the things that Maryland has learned is that if you're going to do global budgeting, you need to pair it with care transformation activities, such as increased primary care investments. Next slide. So here, interestingly enough, if you cap at the 2.8% growth rate, the savings are somewhere between, and there's a long explanation in the report, somewhere between nil to about 7% in hospital costs. Again, remember, you've carved out children's hospitals, critical access hospitals, psych hospitals. And again, if prices come down, enrollment grows. And then next slide, with respect to net impact, here, there's the impact over a 5-year period. So as compared to reinsurance with about a $1.5 billion impact over 5 years, here you're talking about a $6 billion impact over 5 years. Next slide, please. And next slide, and next slide. Okay, so the last thing that we modeled was what would happen in Washington State if the growth expenditure target was met, the board's targets were met. And again, here we're impacting a much bigger slice of the pie. And so again, next slide. So as we indicated that we're looking at well, you know all this is us. Go ahead, next slide. So where we landed is if you were to take all of the current expenditures using CMS data around cost projections, you're talking about saving between about $1.4 billion and $1.9 billion a year if the healthcare cost board's benchmarks were met. So it really gives you a sense of kind of order of magnitude. And next slide. And in terms of economic impacts, again, like like global budgeting, like things that are more aggressive. You're talking because you're depressing cost growth more, there's more positive economic impact that that initiative yields. Next slide. And I think I will stop at that. So that was the really quick version.
Thank you, Jane. What an incredible body of work. And everybody's got the full report, so please dig in. I'm going to ask that we change up the order a little bit. I'd like Evan Klein from the Healthcare Authority to go next, and then we'll have Ingrid go after Evan. But before we do that, are there questions for Jane from the board on that nice light topic of all those great suggestions that they are studying? And maybe the group wants to hear all three presentations, and then we'll do questions.
How long do you expect this meeting to go on?
I think we're going to need at least about 20 more minutes. Sorry, Margaret, we will definitely adjust to 3 hours next month. Evan, do you want to go ahead?
Yeah, thanks, Sue, and thanks everyone else for having me here today to chat with you about a couple of piece of legislation that the Healthcare Authority is planning to run this upcoming legislative session, or I should say at least has submitted to the governor's office for contemplation for this upcoming session. And I know that we're a bit over time on the agenda, so I will attempt to be brief. Let me ask, Mandy, do you have my slides available? And
We are
are they
screen sharing them now, Evan.
Great.
Yep, we
Thank
see
you.
them.
Okay. We'll make sure that I can see them too. All right, awesome. So you can advance from here just to the background slide, so one slide further. So I'm going to talk to you about 2 bills that the agency is proposing among 6 total pieces of legislation that the agency has put forward for this upcoming legislative session that are really kind of within the purview of the board. I'll try to be brief. I have a lot of material within this presentation that provides some additional background and context for why we're contemplating these bills, but I'll stick a bit to kind of the structure of the 2 concepts. Just to orient you first, though, the first of the 2 bills that I'll cover is related to access and affordability for our public and school employee benefits programs. So by way of a brief background, there has been a lot kind of happening in this space over the past couple of years, all of which I think has been coming before the board. So none of this should really be new news. But thinking about recent contract termination notices by large health systems and hospitals, hospital services and their costs and cost growth, as well as the impact on premiums associated with those hospital costs. Within the PEB and SEB program, particularly, rates have grown by approximately 20% from 2021 to present, with the expectation that rates are going to continue to increase next year. As well, kind of within the broader state context and within the purview of the Healthcare Authority, we're also looking at what's happening in the commercial insurance market as juxtaposed to what's happening in Medicaid. You've heard a lot of today about the need for investments in the Medicaid space, particularly in primary care. The state has also just recently invested a significant with a significant increase in spending for hospital services through our hospital safety net program that took effect earlier this year, starting January 1st of 2024. And we'll see an increase in over $1 billion in Medicaid spending on hospital services through the state. We've also been looking at what's happening within Washington and other markets, as well as within other states, kind of surveilling what's happening with other concepts related to affordability and teasing out what may be an effective approach here in Washington. So have some content within the presentation, but that I'll largely skip over that reflects on our experience with the Cascade Select Public Option Program that we jointly administer with the Health Benefit Exchange, as well as a reference pricing statutory program that was enacted in Oregon in 2019 that has shown some significant cost containment for their public employee benefits program just south of us. Next slide. Actually, you can move down if we want to, let's see, the summary of the bill. I believe it's slide 13. So like I said, some content in here, just providing some background. It is in your packets. It has some information on notions of cost shifting, relationship of price and cost, some background on our claims trend and premiums in the PEB space as well, all just there to provide some context for why we think some sort of regulatory intervention in our PEB and sub programs may be helpful. So just in terms of a summary of the bill, this is, like I said, largely looking at some structures that are in place both within our public option program and within Oregon's public employee benefits program. And I'll also note there are some other states exploring things that are similar as well that we've been working with on the side. But the bill would apply to all fully insured and self-funded medical plans within the PEB and SEB programs. So that's both our UMP plan as well as, currently today, Premier and Kaiser Permanente options, as well as any future options that would be available within that portfolio. It requires hospitals to participate in network upon a good faith offer to contract from a carrier or RTPA. This is akin to the structure that's in place in the Cascade Select program. And largely what we're looking at here is we think that network access is really critical for our clients, as well as affordability. And to address one, you have to address both at the same time, recognizing that if you required participation in networks but did nothing on price, it could lead to ballooning costs. If you just tried to contain price for providers, and cost of services, but did nothing on network access, it could lead to providers leaving networks and ending up with network access concerns. So starting here by trying to take that on through a participation requirement upon an offer to contract doesn't require that a carrier contract with every hospital in the state, so that they would still have the ability to control their networks, but would require facilities to participate in network upon that good faith offer. And then it caps reimbursement for inpatient and outpatient hospital services. It starts with a cap at 200% of Medicare beginning in 2027, moving down to 190% of Medicare in 2029. So kind of phasing it in over a 4-year period. It doesn't set rates for any specific hospital. So it's setting that cap at the carrier or TPA level. So it's saying that within UMP coverage, for example, that the total spend on inpatient outpatient hospital services couldn't exceed 200% of Medicare. It also includes a floor for critical access and sole community hospital services. So this is a statutory structure that's in place in our Cascade Select program to ensure that we're not dipping below certain thresholds for some of our most critical facilities in the state, and that there's kind of an adequate floor for reimbursement for those facilities. So mirroring some language that's in place there. Next slide. The bill also contains some additional components of reference pricing that are seeking to set floors and expand reimbursement. So to Jane's points earlier, and in reflecting on the OIC affordability report, I think one of the lessons learned there is that reference pricing isn't just a tool used to contain prices or contain costs, but can be a tool to incent investment or require investment in that space. And as she noted in the presentation, we see floors for reimbursement, or we see average reimbursement for services outside of the hospital setting that tend to be much lower than those hospital services or specialty services. This is also in line with the agency's strategy to invest in primary care in the Medicaid space as well as in behavioral health. We've seen a lot of engagement, particularly with the legislature, on investing in behavioral health to hopefully increase and sustain access there. So this bill would seek to set floors for reimbursement for primary care and non-facility based behavioral health services at 150% of Medicare. So the focus being on ensuring that we're increasing reimbursement up to those floors and then sustaining that reimbursement moving forward. To some comments that were made, I think, during the public comment period earlier in the board meeting around ensuring that any cost containment be driven down to consumers, the bill also does require that carriers consider changes in reimbursement from the legislation in future rate development cycles, with the goal being that if there are any adjustments to reimbursement that impact premiums, or in this case, bid rates for our plans, that gets driven down as well. And we have decision package, a budget package that rides along with this legislation that outlines in more detail what that cost containment might look like over time under this proposal. Next slide. So then kind of wrapping up on this bill, and then happy to pause for a second, but just kind of, at a high level, setting some goals and expectations. The hope here is to maintain access to critical hospital services. We have seen, threats of termination as well as some contract terminations in this space, and we know that's incredibly disruptive for our clients, and we think that maintaining access and ensuring access to those critical services for state and school employees is important, and see this as a regulatory intervention to try and do that over time. It is also a proposal to increase access to behavioral health and primary care services. We know rates are only one component that drive access. There are workforce challenges. There are other challenges related to administrative simplification and prior authorization that we as an agency have been engaged with, particularly with the legislature and with providers over time. But we do see rates as one component of access, and our hope is that by increasing those kind of floors for reimbursement, that it can generate some increased access for our public and school employees. And then kind of in the aggregate, still looking at a measure that would contain costs. So to Sue's points earlier, this is in some respect a proposal to try and redistribute our spending towards high value preventive services. The initial modeling that we completed for this was around our UMP program, so not the entirety of PEB and SEV coverage, but did show cost avoidance starting over around $50 million and $55 million in 2027, and then increasing by 2030 to over $150 million. And we have in our decision package some broader figures now that outline cost avoidance relative to the entire market, so including our fully insured plans that exceed these numbers. And happy to provide more detail on that if there's interest. And then also kind of highlighting some of the investments. So in the behavioral health space, the initial modeling suggested that just for UMP, so again, just for a portion of our coverage, it would increase spending by over $20 million per year. I will pause there if it's helpful to see if there are any questions, or I can just continue on. I want to provide a little bit more background on a second piece of legislation on the APCD as well. But whatever makes the most sense, Sue, Andy.
I'm not seeing any hands. I think everybody's, Eileen's got a hand up.
Just a quick one. Is the reason that it's 27 is you can't implement this any quicker?
Correct. We felt that the earliest
perspective, they want savings in the next biennium, and
yeah,
so this is a 4-year outlook.
Yeah, so it does touch the 4-year outlook in their budgeting cycle because the 2027 plan year, there's roughly 6 months that are impacted within the 4-year. We would have concerns about trying to implement this any sooner, particularly on the carrier side. We would expect there is some recontracting that would have to take place. So just thinking about the timelines, we think it's probably the soonest that we could implement, but your points are well taken.
Right. Could you do the UMP first and like in the next? Just saying, it's easier to pass a bill when there's savings attached.
Stay tuned. Okay. Do you want to move us on quickly, and then we'll finish up with Ingrid, because I know we are soldiering on, but we got to wrap up here soon. Do you want to take us into the APCD changes?
Yeah, I'll be really quick, and you can move down to slide 19. The short of it is we're also contemplating a bill this year we've submitted to the governor's office related to the all-payer claims database. The proposal really takes on two things. One is we are currently operating without a third-party lead organization to run and administer the APCD, and the agency is functioning in that capacity, but kind of to some extent with limited capabilities and outside of the kind of core requirements that are in statute. So we are seeking some flexibility in statute to allow the agency to function as the lead organization or procure for a lead organization, acknowledging we've had some issues securing a successful bidder for that program for the past couple of years. But I think the major component of the bill is looking at, there's a current definition in the bill around proprietary financial information. It does not impact the data that's being taken in and submitted to the all payer claims database today, but it does create restrictions on utilization of certain data by certain entities, particularly the public and policymakers. And that, for the most part, is a control on negotiated rates and the rate that's being paid between a carrier or a payer and a facility or provider. There have been some changes at the federal level through the transparency and coverage rules that came down from CMS that dictate that that information be made publicly available by payers and insurers today. So we see this as there are already some requirements where this information is being submitted into the public domain, but we're restricted on utilization of it through our all payer claims database. So the legislation is hopefully truing up where we are in state statute and the functionality of the APCD with those federal requirements. I'll leave it at that. Happy to answer any more questions there may be on that bill, but wanted to give you at least a quick overview. And thank you for allowing me the time.
Thank you, Evan, for taking us through that. And board members, you can follow up with any of the members of our team for other in-depth questions. Ingrid, we're going to turn to you to finish up this chunk of work. And then I just have a few comments, and then we are going to end this meeting.
Thank you. I will be incredibly brief because I know people have places to go and people to see. I just reminder board that the exchange does eligibility and enrollment for both our state Medicaid program as well as for qualified health plans. So we serve 2.2 million members. Big kudos from me to my staff, Leah Hole-Marshall, as well as Laura K. Scheitschke, who staff our work in engaging in this board. And I preview for you that we have a new person coming. I can't wait for all of you to work with Shirley Prasad. Will be a colleague, peer to Evan, will be our government affairs director. I think importantly for this board to know, she comes with background from WSHA, CHPW, and Washington Association of Community Health. So as working with across stakeholders, I am pleased that we'll be bringing a lot of that background and lens to our exchange work. Reminder that the exchange is a public-private partnership governed by a bipartisan board with ex officio board members that include Director Birch from HCA and the insurance commissioner from OIC. And our board, as both of Jane and Sue, is incredibly frustrated at the continued increases in premiums, average of 10% the last 3 years. It's becoming increasingly unaffordable for us to catch people who don't have Medicare, Medicaid, or employer-based insurance. And before the ACA would be uncovered, who would be uninsured, but now are having the benefit of buying through our market. So we are enthusiastic about supporting this board's recommendations. We can move forward on facility fees, on primary care. This work is just critically important. Just a quick word in what we have span of control over on it here at the exchange. Jane, you mentioned the federal enhanced subsidies are scheduled to expire at the end of 2025. 26 could be really brutal. So things will get much more expensive without that federal help. Number one priority is the state subsidy program, Cascade Care Savings. Our board has also directed us to fully standardize the exchange market so that we have a simpler shopping experience and we protect people from unanticipated costs that feed medical debt, which this group has talked so much about. And finally, this reference-based pricing, I think the OIC report really points to it as logically a very clear and important next step. So we are enthusiastic about reference-based pricing. And Evan, thank you for your presentation. We will partner deeply with HCA on that proposal. It may be an opportunity for us to also tag on some needed improvements to the reference-based pricing structure in our public option Cascade Care Select, including a floor for behavioral health as an important tool. So we stand in solidarity with our partners here and with this board, and I promised I'd be fast, so I'm done.
Thank you, Ingrid. And I'll attest, Jane and I get to sit with her board and they really do some amazing work. So board members, you have been amazing, and the public, thank you for hanging with us. I just want to make a few closing comments. We are currently working on a draft of the legislative report. When that draft is ready for release as a draft, we will get it to you, board members, and the draft on our webpage for public comment. We anticipate a version that will be available before the next board meeting, but there will be chunks that still have to be detailed and whatnot as we get comments back. I want to thank everyone for participating today, for your very thoughtful, wise comments and actions. We really appreciate the time and effort and that each of you have given on all of this work. It's not easy work. We appreciate the public giving us their perspectives and information. The engagement for this work is crucial. We have to keep working together to make healthcare more affordable and to just clearly understand all of this cost information. And really, we want to just keep striving to enhance price transparency so that we've got the trust of Washingtonians. I remind you that the recording and the summary of this meeting will be posted shortly on our website, and our next meeting will be on November 7th. We are going to extend it from 2 o'clock we're going to extend it to 3 hours just because we will go over 2 to 5. And I look forward to seeing all of you at that next meeting. Please be in touch with us if you have questions or follow-up. And thank you all for your input. And this meeting is adjourned. Bye all.
Thank you.